Hi everyone. So today we are going to discuss about one retinal condition that still fascinates me till date, which is submacular hemorrhage, which is absolutely a medical emergency. So there can be various causes of submacular hemorrhage, the most common being trauma, ARMD, PCV, and retinal artery macroaneurysm. But there are a few uncommon causes that need to be considered. That is secondary to myopia, Terson syndrome, or vascular diseases like diabetic retinopathy or vein occlusion. Why do we need to treat these cases? So what happens is when there is a submacular hemorrhage, the blood tends to accumulate between the RPE and the neurosensory retina. And over a period of time, there is clot retraction. And because of that, the photoreceptors get permanently damaged. The second reason is because of chronicity, there might be toxic effects of the iron that is accumulated, which can again lead to photoreceptor apoptosis. And because of long-term accumulation of this blood, there is a diffusion barrier between the RPE and the neurosensory retina, again leading to photoreceptor death. Hence, submacular hemorrhage has to be treated as early as possible. What are certain signs that we need to look for? So, of course, we need to look at what kind of extent the submacular hemorrhage has, whether it's a small hemorrhage or it covers the entire posterior pole or even beyond. We also need to look at the surrounding changes. Like in this case, where there was a small submacular bleed with no evident cause, but when we looked at the periphery, there was a Roth spot, meaning that this hemorrhage was very likely to be secondary to a blood dyscrasia. Fellow eye is extremely important. Look at this case where we could see some macular hemorrhage, some exudation that was again at the posterior pole. But when we looked at the other eye, there were confluent drusen that was surrounding the central vessels. So here I could conclude that this is secondary to age-related macular degeneration or a PCV. And of course, last but not the least, history taking and systemic correlation, extremely important as an ophthalmologist. Now, there is a variety and a platter of treatment that have been described in the literature for submacular hemorrhage. But the most important thing we need to consider is it's an emergency condition and it needs to be treated as early as possible. So let's look at a few examples. So this was a young guy with a large submacular bleed. But when we looked at the surrounding, we could see that there is a yellowish area just passing over the submacular hemorrhage, which was actually a choroidal rupture. So this case was advised a pneumatic displacement. And 2 months down the lane, the blood had completely displaced inferiorly and the macula was free of hemorrhage. Let's look at another case of a 60-year-old gentleman with a large submacular bleed that was even extending beyond the posterior pole. So when we did the ICG for this patient, there was a hotspot which absolutely corresponded to the tall notched PED. Hence, this was a case of a polypoidal choroidal vasculopathy which has bled. So once this was diagnosed, the patient was advised an anti-VEGF therapy along with intravitreal TPA and again pneumatic displacement. And as you can see sequentially, the pictures show displaced macular hemorrhage. So to sum it up, submacular hemorrhage can present in two ways. One, with the vitreous clear, one with a vitreous hemorrhage. So if there's a vitreous hemorrhage, there is no other option other than to go in, clear the vitreous hemorrhage, and then to take a call what to do next. But whenever you have a submacular hemorrhage with a media clarity, we need to find the cause. And that is where an OCT, FFA, or an ICG can help. And once the cause is known, treatment options are in terms of anti-VEGF therapy, pneumatic displacement, and use of intravitreal or subretinal TPA. Hence, moral of the story, find the cause of the hemorrhage, the duration, the extent. Extremely important to look at the systemic control and correlation. And as an ophthalmologist, it's very important to have a realistic counseling and give realistic expectation to these patients. Thank you very much for patient listening.